And then Carolyn Pumares is also on the line. She is the other member of the National GPRA Support Team. So today I'm going to give an overview of GPRA and GPRAMA, and then I will also give an introduction into the National Data Warehouse, which is where GPRA data is now reported from, and that is through the Integrated Data Collection System, and we also call that IDCS for short. I'll go into a brief introduction on the National Data Warehouse data exports, and then give some details on how sites can monitor and improve their GPRA results with IDCS. Some examples of what the data looks like when we do download it from IDCS, and then we will have time at the end for questions and comments. So feel free to stop me at any time if you have a comment or question about the current slide. Okay, so first I'm going to give a brief introduction into GPRA, GPRAMA. So hopefully everybody is familiar with these terms. GPRA is the Government Performance and Results Act. It is a federal law that was passed by Congress in 1993, and it requires that federal agencies demonstrate that they're using their congressional funds that they receive efficiently and effectively toward meeting their mission. And IHS has been reporting on GPRA data for over 10 years. And then in 2010, the Modernization Act for GPRA was passed, which we call GPRAMA, and that is an update to the GPRA law, and it requires federal agencies to use performance data to drive decision-making and where the agency is going with all their decisions in the future. We began reporting on GPRAMA in fiscal year 2013, and with GPRAMA there is a smaller subset of measures that the agency focuses on. So most of the GPRA measures are reported in the IHS budget, but the GPRAMA measures actually get a little bit higher priority, and they are reported in the Department of Health and Human Services budget as well, so they get seen on a broader scale by more people. And then GPRA and GPRAMA data is reported in the IHS budget, as I mentioned, and it's used for justification for the funding that is being requested in the budget. Okay, so for fiscal year 2020, we do have 26 clinical GPRA measures. There are 5 diabetes measures, core glycemic control, controlled blood pressure, statin therapy, nephropathy assessment, and retinopathy exam. We have 3 dental measures, access to dental services, sealants, and fluorides. And then 4 immunization measures, flu vaccines in children, flu vaccines in adults, adult immunizations, and childhood immunizations. 3 cancer screening measures, cervical or pap screening, mammography, and colorectal cancer screening. And then 5 behavioral health measures, alcohol screening, domestic violence, intimate partner violence screening, depression screening in adolescents, depression screening in adults, and then expert. And then we have 6 measures that we call prevention measures, and those are tobacco cessation, HIV screening, cardiovascular disease statin therapy, childhood weight control, breastfeeding weight, and then controlling high blood pressure, which is our million hearts measure. And you'll see that we have 1 measure that's in red, that's the domestic violence screening. That is our GPRAMA measure that does get reported up in the HHS budget. Okay, so the clinical GPRA data, it is collected and reported throughout the GPRA year. And as I mentioned, beginning in 2018, we started using the Integrated Data Collection System, otherwise called IDCS, which is a Data Mart at the National Data Warehouse. Another change that happened in 2018 is that the GPRA year changed from July 1st to June 30th to match the fiscal year of October 1st to September 30th. The data collected is done via the exports that each health program sends to the National Data Warehouse. The data is cumulative throughout the year. So each month, hopefully sites are sending in their data, and then each data export is added on for the year. So you get a representative of how your site is doing on each of the clinical measures throughout that fiscal year. The IDCS data from all reporting clinics are aggregated into a national result. So all urban, tribal, and federal sites who export their data to the National Data Warehouse, all of that data is aggregated and we get one national result, which is an average of all the scores from all the reporting sites. The national results, as I mentioned, include data from federal, tribal, and urban Indian health programs. Prior to the use of IDCS, urban program data was not included with the federal and tribal data, but with the use of IDCS, we now are reporting data from all sites together as one national average, so the data is more comprehensive and more representative of all of the sites throughout IHS. And then also with the change to IDCS, health programs can report data for GPRA regardless of which electronic health record they are using. So for those sites that were not using RPMS prior to 2018, they could not have their GPRA data included in the national or area totals that were reported. But with the switch to IDCS, the National Data Warehouse can accept data from both RPMS systems and non-RPMS systems. So that allows all health programs to export and have their data included in the GPRA results. Okay, so one of the important definitions with GPRA is the denominator that is used for each of the measures. And with the change to IDCS, we are now using the IDCS user population as the base denominator. And to fit into that definition, the patient must have been seen at least once in the 3 years prior to the end of the report period, and that's regardless of clinic type. And the visit has to either be ambulatory or a hospitalization. The patient has to be alive on the last day of the report period. The patient must be American Indian or Alaska Native, and they have to reside in a community that's specified in the site's GPRA community taxonomy. So, and usually for most areas, that is the sites that are assigned in the CHOSTA. Okay, and this is what we call our GPRA measure numerator and denominator cheat sheet. So this lists the numerators and denominators in very brief form for each of our GPRA measures. And I'm not going to go through all of these, but they are included in the presentation. And so if you ever have a question on what each measure is reporting on, and this is a good quick place to look. And then later on in this presentation, I'll show you where you can get more detailed information on each of the measures. Okay, and this is just the second page showing the remainder of the GPRA measures. So now I'm going to go into an overview of the National Data Warehouse. So the National Data Warehouse is a data repository that is run by the National Patient Information Reporting System, which sometimes you will hear called NIPERS. And that was started in 2006. So the National Data Warehouse is a data warehouse environment where it stores all of the national data that all of our urban, federal, and tribal health programs export to them. And usually it consists of registration and workload data. The National Data Warehouse gathers, stores, reports, and allows access to accurate historical data for all the data that's been exported throughout the years. Each of the different groups within IHS, whether it's behavioral health, GPRA, immunizations, they can get custom designed reports that are specific to their needs for planning purposes throughout the agency via the National Data Warehouse. Okay, so the National Data Warehouse accommodates what we call individual data marts for each of those different groups. And one of those data marts is the IDCS Data Mart, which only includes the GPRA data. So all of the data from all of the export goes into one database. That's the General Data Mart. And then the National Data Warehouse does an unduplication process where they make sure within each area no patient is being counted more than once. And then they also have to match up the workload visits with the registration visits to make sure those all match up. Once that's done, the data is put into the National Data Warehouse Mart, where each of the individual Data Marts can pull the specific data needed for that reporting purpose. So the GPRA Data Mart only has the data needed to be able to calculate the GPRA results. And then one nice thing is that the data marts can be refreshed or purged, and then all the data re-imported from the National Data Warehouse whenever necessary. So if there's any issues with any of the data marts, they can get rid of all that data and then just re-import it from the giant database that contains everything. And this is just like a brief overview showing how the data mart is set up. So the National Data Warehouse can accept RPMS data, non-RPMS data, CHS files, fiscal intermediary files, and then also non-RPMS files. All of that gets put into the National Data Warehouse where they do all of their data cleanup, and then from there it goes to the general data mart and then into the individual data mart. So it sees, yes?
One quick question. Someone's asking about what percentage of non-RPMS users are reporting, since there is now a bridge for non-RPMS sites to upload their data to the NDW. I'm sorry.
Nationwide, I'm not sure what the percentage is. I know almost all the areas are working with their non-RPMS sites to get their exports in, because the National Data Warehouse is not only used for GPRA, it's also used for user pop reporting and workload reporting, which, you know, the user pop can be important for different funding purposes. So I believe most of the non-RPMS sites are either already exporting or in the process of getting their export set up. So I think it's probably a very low number that are not reporting. Okay. So the IDCS Data Mart is a centralized performance data mart that is built within the National Data Warehouse. With IDCS, we can run secure, on-demand web-based reports for our GPRA measures. And right now, they can be run at the service unit, area, and national levels. We currently don't have the ability to run GPRA reports at the individual facility levels, although the IDCS staff is currently working on getting that functionality built in. We just don't have a deadline yet or a due date for when that will be accessible for everybody. And so for those of you who have been working on GPRA for a while, you'll remember we used to use the clinical reporting system, which was a software package within RPMS to report GPRA. But then beginning in 2018, we switched over to using the IDCS Data Mart. So now the CRS results are only used for our developmental reports and for GPRA monitoring at the local level. And then one nice thing about the Data Mart is it reduces the burden on each of the individual health programs, because prior to IDCS, each health program had to install CRS at the local site anytime there was an upgrade, which usually was 2 times a year. With IDCS, all of that is done centrally at the National Data Warehouse, so any logic changes are just programmed there, and then reports can be run using the new logic. Also, the health programs don't have to manually run their GPRA reports each reporting quarter. Instead, all of the data comes specifically from the IDCS Data Mart. So why did IHS build the Data Mart for IDCS? So one of the main reasons was, as I mentioned earlier, back when we were reporting only through RPMS, the non-RPMS sites could not have their data included in the national or area GPRA results. So by switching to IDCS, it allowed all 3 of the types of programs, tribal, urban, and federal, to report for GPRA. And then it also allowed the non-RPMS sites to have their data included as well. So now our data is more fully representative of all the health programs across IHS. And then, as I mentioned, the IDCS Data Mart uses any data exported to the National Data Warehouse. So again, RPMS sites, non-RPMS sites, and then it also can take fiscal intermediary data. The Data Mart increases the efficiency of timely reporting compared to CRS. With CRS, we were having health programs run their GPRA data just on a quarterly basis after 2nd, 3rd, and 4th quarters. With IDCS, we can run reports as frequently as we want, and the data is updated as frequently as sites are exporting their data. Okay, so this is just a brief overview of IDCS. So with the reporting process, IDCS allows for centralization. So the measure logic is programmed centrally instead of having to be downloaded at each health program individually every time there's an update. And again, the measure reports are run centrally instead of requiring each health program to run it and send their data report to the area office. And then measure calculations follow the patient. So as with user population, the data or the GPRA results are for each patient are based on the community of residence that the patient lives in. So if a patient lives in community A but goes to health clinic B, whatever clinic is assigned the community of residence that that patient lives in will get the data and the credit for any of the measures that are met for that patient. So it's all based on community of residence. Wherever that patient lives, whatever clinic is assigned to that community will get the credit for the visit. But also, if the patient's going to other clinics, it allows each clinic to get credit for tests or procedures that were done at clinics that aren't their home clinic. And then reports are available at the national area and service unit levels currently, and hopefully soon we will also have facility level data. The reports and the IDCS Data Mart are refreshed on a weekly basis, so all exports that are sent in for each week, that data is refreshed and we get the newest data available anytime that we run the reports. And then again, the results represent the federal, tribal, and urban sites that participate instead of just the tribal and federal. So one of the questions we commonly get is when sites are monitoring their GPRA data, they'll notice that there is a significant change in their denominators. And usually this is because the National Data Warehouse updates the user population draft 5 times per year. And so each time there's an update, any new patients that have met the requirements for being included in user pop are then included in the denominator. So these are the dates that the 2019 user pop drafts were released. So as you're looking at your GPRA data, that is something to keep in mind. If you do see a large change in your denominators, this could be one of the reasons. So usually it's around the same time each year that those drafts are sent out. And you can always check with your either area GPRA coordinator or your area stats officer at your area office, and they can often tell you if that is the reason for the change in user pop counts. Another question we commonly get is why are the results from CRS and IDCS different? So we have a few sites who are still using RPMS, and those sites can still use the clinical reporting system to monitor their GPRA data at the local level. But often those results are different from the results that the sites are seeing when they get their GPRA reports from the area office. And the main reason for that is when a site is running a local RPMS report in CRS, it's only including the data that's specifically in their RPMS system at their health program. Because you're not getting data from patients who live in your community of residence but are going to other health programs throughout your area, you're only going to be seeing those measure results for patients who are actually having visits at your facility. With IDCS, as I mentioned earlier, since it's based on community of residence, since almost all the sites do export their data, any clinic that that patient goes to will have the data exported, meaning that the clinic that owns the community of residence will get all of the screenings that were done at other health programs and all of the tests that were done. So it's more comprehensive, and it'll also show you patients that are not actually being seen at your clinic, but that are being included in your GPRA results. Another change is the denominator. So in CRS, it uses what's called the GPRA user population, and this includes patients who live in a community of residence that are assigned to your service unit, but they have had to have a visit at your service unit in order to be in your system. With IDCS, as I mentioned earlier, any patient who attends a tribal, urban, or federal center who is exporting data will be included in your denominator. And then as for the results, again, for RPMS, the calculations are based only on the patient registration and visit data that is in your health program's EHR. And with IDCS, it's based on the patient regardless of where they go. So that's the main reason you'll see differences. Usually the IDCS data, it has a bigger denominator, and often that might result in a lower result for each of the measures because you're having larger denominators. And now I'm going to go over the National Data Warehouse export. So each service unit exports both their registration and their workload data to the National Data Warehouse. And these exports are used for the IHS user pop estimates, the workload counts, and then also beginning in 2018, the GPRAMA data. Currently, most of the RPMS sites do export their data monthly. Sites who are using RPMS can set up their systems to automatically export their data, so it's pretty simple for them to have it sent over. For the non-RPMS sites, there is a lot of variation in how often they are exporting their data, sometimes due to just difficulty in getting the exports in. And then also they do have to do it manually. We do highly encourage all sites to export at least on a monthly basis. That allows time to catch any errors in the data, to make sure your user pop counts are correct, and then also that impacts your denominator counts as well. So if you are a site using a non-RPMS system, we do highly encourage you to work with the National Data Warehouse to be able to get your data in at least on a monthly basis. And it also helps us monitor the GPRA data throughout the year and make sure it's more accurate. We do have some sites that do large data exports at the very end of the year, and so it makes it much harder to track the results throughout the year and plan to see which measures we're going to meet and not meet when we don't have a full set of data throughout each month. And as I mentioned, IHS strongly recommends that all health programs export their data at least monthly. It ensures data errors can be corrected prior to the end of the fiscal year, which increases data accuracy for user pop, workload, and GPRA reporting. And it also allows each service unit to monitor their progress on GPRA and plan any improvement strategies that may help you get better results with GPRA. And then as I mentioned, our PMS programs have an application which will set their data to automatically export each month. And then non-RPMS programs have to either send their data in an HL7 format, or I believe there is also a simplified data format that they can send them in. But the non-RPMS programs do have to work directly with the National Data Warehouse in order to get their data exports in and to set up the export process that works best for your health program. So the export requirements and the initial export that gets sent in by each clinic, if you've never sent data to the National Data Warehouse before, it should include all the patient registration and encounter data beginning with October 1st, 2000, and then forward to the present time. And that allows the National Data Warehouse to have that history, and then also many of the GPRA measures have look-backs up to 10 years. For instance, colorectal cancer screening for a colonoscopy can look back 10 years in order to meet the measure. So the further back your data goes, the more likely it is going to be accurate for your GPRA results. If you are a site that has submitted to the National Data Warehouse via RPMS before, but have switched to a non-RPMS system, then they ask that you only send data starting with the date that you made the switch. So they'll already have your previous data from RPMS, so you'll only need to send in the newest data that is coming from whichever new EHR that you're using. And then when you do send in the files, NIPRs can receive it either in a single file or broken into separate files by year. When you contact them to get your export set up, usually they can work with you to figure out the best way depending on how many data files you do have to export in. Christine, so yes.
Another question, I think working off of the previous slide of describing exports and defining CRS versus IDCS, a question was asked, is there a way to modify the communities within an urban GPRA's community taxonomy?
So are you meaning in RPMS or which communities are assigned to you?
Keep typing now.
What is fine? Okay. So for that one, you'll have to work with your area statistical officer, and they are the ones at each area office who work with headquarters in getting the communities assigned. I know for the urban, there are some issues with which communities are assigned due to having tribal health programs that are in close proximity. And I know Rose Riaki is aware of that issue. And I think she has been having conversations with the National Data Warehouse staff to see what can be done to remedy that. But the best thing to do first is to contact the area GPRA coordinator or the area statistician at the area office that you're located in. And I do have a slide coming up later on in the presentation that has the name and contact information for each of the area staff offices, so you'll know who to contact if you aren't sure who that is. Okay, so for user pop and workload, there are some required data elements that the National Data Warehouse needs to determine if a patient meets the user pop definition and to see if the workload visit should count as a workload visit. So that is a list of those elements, and I'm not going to go through them, but you'll have these included in the presentation if you download it. And then once we started collecting GPRA data through the National Data Warehouse, there are additional data elements that are required in order to determine if a visit or patient meets the requirements for the GPRA measure. So these are those additional elements that have to be added to the export file in order for the GPRA results to be accurately calculated. So there is a data export tracking mark, and that is located on the National Data Warehouse website. And so when you go to ihs.gov/NDW, one of the top options in the blue box to the right is export tracking. So if you click that, that will bring you to a page here, and it looks just like this. And what this site does is it allows you to see which files the National Data Warehouse has received and which ones have been loaded onto the production server and which ones were rejected due to errors. So when you get onto this site, there is a drop-down for you to choose which area your health program is located in. And then once you do that, it'll list all of the health programs that are within that area. So you can select your health program. And then it will bring up a screen showing each of the export files that the National Data Warehouse has received from your service unit. And any that were loaded and did not have any issues will be listed in black, and it'll tell you the date of the visits that are included in that file, and it will tell you when it was received and when it was loaded on the production server. And then any files that are rejected due to errors will show up as red. As you can see in the example, there's the 2 red files at the bottom. That lets you know that there was something wrong with that export file. And usually at each health program and at their area office, there are people who are set to receive the notification for the exports. So someone at your site, and usually it's whoever is involved in sending the export, did get an email listing what the errors were, so you'll know how to fix them. And if not, you can always contact your area statistical officer, and they're usually included on those emails as well. And they also have a data quality report that they can send you, which I'll cover now. So the National Data Warehouse also produces what we call data quality reports that tell us which files have errors in them and what those errors are. So there are both user POP data quality reports and there's workload data quality reports. So the 3 main data quality reports for user POP are the registrations not included on user POP reports, And that will list all registrations that are missing a unique identifier that allows the National Data House to even identify the patient. And then there's another report called the Registrations Potentially Countable. So these are files that were exported that are missing an identifier that the National Data Warehouse uses to determine if a patient meets the qualification for user pop. So those are usually community of residence, tribe, beneficiary, or blood quantum. If any of those items are missing, the National Data Warehouse software can't determine if that patient meets all the identifiers needed to be able to determine if they should be counted in the user population. And then there's also a missing registrations by facility, which lists all workload visits that are not linked to a registration file. And this is an example of what those data quality reports look like. So it'll give you a registration code for each file. So that allows you to look up that file and make whatever errors are listed. It'll tell you the date the file was exported, and then it'll tell you where the error is. So in this example, the tribe code was missing in each of these files. So once that's corrected at the health program level, they can re-export the data, and then it should upload with the next export. And then if they meet the criteria, they will be counted in user pop or workload. And then again, there's also some workload reports, and those are workload reportable visits that are not included on the workload report. And these list a visit that's missing a unique identifier that allows the National Data Warehouse to determine if a visit meets the definition for a workload visit. And then there's also the potentially workload reportable ambulatory visits. So those look exactly the same as the user pop. They just have the different data elements that are needed specific for workload. And these are accessible by the area staff officer. I don't think any of the health programs have access to these, but I believe most staff officers do send these out at least once or twice a year to each of the health programs or service units, so you can make these edits. And if you're not getting them, you can always contact your area staff officer, and they can download them at any time and send them to you. Okay, so I know there's a lot of questions about how sites can monitor their GPRA data and improve with IDCS, since some of the results include patients that aren't actually being seen at your clinic, but the patient just happens to live in your community of residence. So first, you can request your GPRA reports anytime throughout the year from your area GPRA coordinator. The area GPRA coordinators all have access to the IDCS Data Mart and can download service unit level reports or data at any time and send that information to you. You can also request to your area GPRA coordinator that your name be added to the email list that the NCUIH uses to send out the GPRA data, I think each month that they send it out. And then the National Data Warehouse and the IDCS programmers are still currently working on what we're calling the E1 access for IDCS. The sites that are on the internal IHS D1 network currently have access, but any site who is not on the D1 network, they'll need to get what we're calling E1 access. And that will become available once it's all programmed in, and that'll allow programs who are not on the D1 network to be able to log into IDCS and view the data for their facility. So they are still working on that, and again, we have not gotten a due date for when that's going to be available. But you can contact your area GPRA coordinator, and there is an E1 access request form that you can fill out. And once E1 access does become available, that will make sure that your approval is already there and your site is in the queue to get access. And then I do see a question, are area stat officers different from area statistical officers? It's the same, yeah, same exact person. That's the, and it's stat, sorry, I should say statistical. And I do have a slide later on in this presentation that has the listing of who the staff officers are in each of the areas, so you'll know who to contact. Okay, Another way to make sure that your data is accurate and that you're monitoring your results is to use the GPRA's environment and make sure that the data included in the standard code book is correct. So the standard code book is what the IDCS Data Mart uses to determine communities, which communities are assigned to which service units. It has pretty much all the codes that are used for visit types or any of those things that are used in the programming. So it's really important to make sure that the data for your service unit in the standard code book is correct. And so, here is a link to the standard code book on the IHS website. And the main tables that you would want to look at for your service unit are the standard code book tables, which is the top link listed here. And this is an example of one of the tables in the standard code book. So this is just the education codes that are used within IHS. So each of the different items that both the National Data Warehouse and IDCS Data Mart use all are based on codes that are in the standard code book. So for service units, each service unit has an area code and a service unit code. So I don't know if many of you have heard of ACFAC code, which stands for Area Service Unit Facilities. So every single health program within IHS has an ACFAC code assigned to it. And so what's important is making sure your health program is listed under the correct service unit, especially because currently user pop and GPRA are reported only at the service unit level. So the area code here is listed in the second column, followed by the area, the service unit name, and then you also want to make sure your service unit is listed as active. If it's listed as inactive, the National Data Warehouse won't track the data for your service unit. Okay, and here's the other important table. These are the communities of residents that are assigned to each service unit. So each service unit has a set of communities that are assigned to them, and so any patient living in those communities are what gets assigned to those specific service units. So here, you could look up your service unit by the ASU code, so your area service unit code, and then once you do that, it'll tell you all the communities that are assigned to that specific service unit. So make sure to take a look and make sure the communities that you're seeing assigned to your service units look like they should be. You know, every once in a while, some of these communities were set up years and years ago. So it never hurts to take a look and make sure that there haven't been any changes. And if you see anything that is incorrect, you'll want to contact your area statistical officer. They're the ones that can go in and request changes to the standard code book. Okay, and again, you'll want to check your community of residents, and this is just kind of a brief example of how to do that. So when you go on to the community table in the standard code book, there's different options you can use to search. And so the easiest one is probably using either your area service unit code or just your service unit name. Okay, and then one of the really important ways to make sure that the data you're seeing from the National Data Warehouse is accurate is to export your data routinely. Often the National Data Warehouse gets service tickets asking questions about why their data doesn't look accurate. And in a significant portion of the visits, the sites had not been exporting all of their data. So there was missing data resulting in lower results than what the clinic felt should be showing. So it is really important to export your data at least monthly or as often as you possibly can in order to monitor your data on a frequent level and make sure it looks accurate, and then also to try and improve on your GPRA results. And then again, if you do have D1 access, you can use that export tracking mark to make sure your files have been loaded, or to make sure if there's any errors that you need to correct in order to be able to correct them and then re-export them. And if you don't have D1 access, again, you can always contact your area, either GPRA coordinator or your area statistical officer, and they can give you that same information. Okay, if you have questions about the issues Data Mart or even some of the GPRA measures, you can contact the IHS IT support desk, and that email address is recently changed from support@ihs.gov to itsupport@ihs.gov. So that's something important to note. If you send it to the old address, it may not get to the help desk. There is also a IDCS Listserv, and you can see the link listed under here, and then also in the web links box in the right-hand side of your screen. Kimberly also included the links to both the IDCS Listserv and the CRS Listserv. So I would encourage you to sign up for both. Even if you're not using CRS, often GPRA-related questions will be posted there, and as well as announcements for GPRA-related trainings. There's also an IDCS user meeting that occurs on the second and fourth Wednesdays of each month. And these meetings allow health programs to ask questions specific to IDCS to the IDCS programmers. So if you want to be added to the notification list for those meetings, you'll want to send an email to Ryan DeLuche, and his email address is listed on this slide. Okay, so when you go into IDCS, usually you'll see a national dashboard as the home screen, and then this is what the area dashboards look like that the area GPRA coordinators have access to. And then once the facility level dashboards become available, this is what they'll look like as well. So in the first column will be each of the clinical GPRA measures. Then it'll show, most likely once the facility level reports become available, you'll see which facility the dashboard is for in the second column. And then the next two columns are the previous year's target and the previous year's results, followed by the current year's target and the current year's results. And this example is from 2018, so you'll see California area 2018 results listed for the current columns. And then the final column tells whether the measure target was met or not met for each measure. And it also will display the data in green if the measure was met, and then red if it was not. So it's an easy way to look to see kind of how your health program is doing. There's a lot of reds, and that means there is some improvement to be looked at. Okay, we do have some training resources that are available if you're new to GPRA or if you just need a refresher. First, we do offer Adobe Connect GPRA training several times throughout the year, and those are listed on both the CRF Listserv and the IDCS Listserv usually. And all of those trainings are recorded and are posted in our National GPRA training room, and you'll see the link there. And these include all the PowerPoint slides and the recorded webinars from all of our trainings. And those include the GPRA 101 training that I'm giving today, there's CRS training, and then we have multiple trainings for the individual GPRA measures. And those are usually held by the GPRA measure leads and give information on how to improve, and sometimes we'll have high performers give their strategies for success on those. So there's a lot of useful information in our Adobe Connect GPRA training room. Okay, and then the CRS website is another useful location, even if you're not using RPMS or CRS. All of the IDCS data that's in logic that is programmed into IDCS is based on the same exact logic that is programmed into the clinical reporting system. So if you have a question about the logic, the CRS website is where you'll go to get the definitions for the measures and also the codes that are included in determining if a patient meets any of the measures. So this is an example or a screenshot of the main clinical reporting system website. And if you look to the left-hand side, you'll see the very top link under clinical reporting system is CRS Software. And if you click that, it'll list all the different software releases that have been put out over the years. This is an older screenshot. So currently, you'll see CRS 19.1 being the most recent one on top. So you click on the most recent one, and then there are two links at the top that come up. The very top one is the measure list and definitions manual. So that's the manual you'll click on to get all of the measure logic and all the codes that are used for each of our GPRA measures. So here's a screenshot from that same manual, and this one is showing the intimate partner violence, domestic violence screening measure. It'll tell you who the owner is for that measure. It'll tell you the denominators and numerators. And one thing to notice, we do have what we call developmental measures, and then we also have measure breakouts that are a subset of the actual GPRA measure. The one you'll need to really pay attention to determine what the GPRA measure numerator and denominator are the ones that have GPRA and the colon in front. Okay, and then under definitions, this is where you will find the specific ICD-10 codes or the CPT codes, any of the codes that are used to determine if a patient meets that measure will be listed here. So if you're unsure if a code you're using is being counted for GPRA, this is the perfect place to look. You can see what code you're using, if it's listed, and if not, then you can see if there's another code that would be a better fit than you can use. Okay, also on the CRS website, we have the Performance Improvement Toolbox. And under there, under Screening Tools and Guidelines for GPRA measures, we have what we call our data entry cheat sheets. And unfortunately, these are for those who are still using RPMS EHR, just because the CRS group doesn't have the expertise in any of the other systems. But if you are using RPMS EHR, this is a good tool to make sure that you're entering your data properly to make sure it's counted for GPRA. So this is a screenshot from that data entry cheat sheet. It'll have each of the measures, and it'll have the numerator and denominator definitions. And then in the last column, it'll have information on how to enter that data into the EHR to make sure it's being counted for GPRA. So you'll see under dental sealant CPT, there's a link. If you click that link, it'll take you to the bottom of the cheat sheet, and it'll show you actual screenshots on how to enter the data. So it's a pretty useful tool if you have new staff who are unsure how to enter data, or if you have tenem locum tenens. This is a good tool to use to make sure data is getting entered properly for GPRA reporting purposes. And again, the IDCS Listserv is a great way to find out about all the GPRA trainings that we have coming up. It also is a great way, if you have questions about IDCS, you can post them here and one of the moderators can answer it. Or if even you have questions of other health programs on what they're doing to improve on certain clinical measures, you can post it here, and all of the other health programs that are on the IDCS Listserv can see your question and then hopefully respond with some tips or tools that you can use. So it's a great way to just keep up to date on what's going on with GPRA and IDCS. And then the CRS Listserv as well. Often our trainings get posted on both, but not everyone has joined the IDCS Listserv yet, so often we'll see questions come through on GPRA on the CRS Listserv as well. So it's probably good to join both to make sure you're seeing all the trainings and questions that come up. And again, the links to both of these Listserv signups are in the web links box on the right side of the screen. Okay, so there's an area GPRA coordinator assigned to each area office. So this is a list of each of the area GPRA coordinators in each area. Tucson currently, the area GPRA coordinator retired, so and I have not heard that they've assigned anyone new yet. But the other areas all have staff who have been there a very long time and are very well versed in GPRA, and many of these are also the stats officers. So if you do have a question that comes up, the first point of contact should be your area GPRA coordinator, and then if they're unsure of the answer, they can always forward it on to either us at the National GPRA Support Team or to Diane at headquarters. And then here is the contact information for the National GPRA Support Team. This will send an email to both myself and Carolyn Pumares. We are the two members, and by using this email address, it ensures that at least one of us gets the email if the other is out of the office. And Diane Leach, her email is here as well. As I mentioned earlier, she is the GPRA lead at headquarters. And then if you have questions on your exports or on if you've recently switched to a non-RPMS EHR, the IT support at IHS.gov is who you'd want to contact. Just make sure to put either ITSEs or NDW data exports in the subject line to make sure that your question gets routed to the correct help desk. And then they can work with you to set up your exports in the correct format. Okay, and that is all I have. Are there any questions related to any of this information? I know it's a lot of information that can be overwhelming.
And this is Kimberly again. If you would feel more comfortable vocalizing your question, you can always unmute your mic or your computer screen and feel free to ask that question. While we're waiting for any questions to come through, I would like to thank Christine for providing this presentation and overview on GPRA. As I mentioned before, this community of learning, we did want to start off with an introduction to make sure that everyone was on the same page around GPRA and GPRAMA understanding. And in our next session, which is actually coming up on November the 13th, listed here, we'll be covering actual intimate partner violence, domestic violence coding measures, providing you with some of those best practices and understanding of what some of those numerators and denominators actually mean in order to support you in actually coding in the correct way. Erica Gunul will be presenting that. She is the National Forensic Nurse Coordinator at IHS. And so we welcome you to attend that next session. If you haven't already received a calendar invitation or have not registered, feel free to do so. And I'll have a last call for any questions.
If you do have any questions, again, you can always contact the National GPRA Support Team at that CAOGPRA at IHS.gov email address. And then also, you can also contact your area GPRA coordinator or area statistical officer. They are a wealth of information as well.
Great. Well, thank you again, Christine. And I'll turn over a few more minutes of your day since we ended a little bit early. I look forward to hearing from you all in November. And definitely if you have any questions or direct input or feedback that you'd like to provide, feel free to reach out to me at kfowler@ncui.org or any ways in which we could improve upon this community of learning too as well. So thank you all.
Thank you, Kimberly.
You're welcome.